We'll be starting in 1 minute. Okay, so good morning, everyone. Welcome to day 3 of our Ophthalmic Support Staff course. Thank you again for allotting another 1.5 hours of your precious Saturday morning to attend this course. So I am Dr. June Pajarillo, and with me is Dr. Paula Cabel, and we will be your moderators for today. So before we start, just a recap on our last day 2 discussions. We had approximately more than 120 participants, and we had very nice presentations and discussions about the operating room, COVID protocols, and about the model employee. So for today, day 3, we will be focusing on the outpatient department, which is comprised of the OPD, the Eye Instrument Center, and we will have discussions on some administrative matters as well as the basic of the history in eye exam. Okay, so before we start, may we request that everyone mute their microphones and not in use. And for the open forum or questions, you can use the chat box, or you can raise your hand, and we highly appreciate questions. So please feel free to ask. May we also request everyone to fill up the evaluation forms per speaker so that we can improve on the course on maybe next year again. So attendance sheets will be posted at the end of the last speaker until 10 minutes thereafter. And certificates will be provided to those who attended all 3 sessions. We will also give you copies of the lectures of all speakers. So it's 8:59. We will start on time. Without further ado, Dr. Paula.
Thank you, sir. So to start off our first lecture, I would like to introduce our first speaker. She is a graduate of Our Lady of Fatima University, and she took her residency training here at ITRMC, and she's also the past chief resident of our department. She is a recent diplomate of the Philippine Board of Ophthalmology. So she will be discussing about ophthalmic history taking and eye examination. So without further ado, I would like to call on our first speaker, Dr. Carmela Gabrilio. Doctora?
Good morning po, thank you, Dr. Cabel, for that introduction. So I will be discussing about basic ophthalmologic history taking and examination. So for ophthalmologic history taking and eye examination, I'm Carmela Gabrilio po. So this is the objective of my report, is to know and how to take the basic ophthalmic history and to know the basic ophthalmologic examination. For history taking is gathering information process from the patient guided by an educated and active mind. Selective guided and progressive elicitation and recognition of significant information. History by skilled person can arrive at a proper diagnosis in 90% of the patient. History taking is composed of chief history of present illness, past ocular history, ocular medications, general ocular medication, general medical and surgical history, systemic and ocular medications, allergies, social history, and family history. So for the chief complaint, this is the patient's own words or non-technical paraphrasing of patient's word. Example, eye redness, or blurring of vision, or flashes of light. History of present illness is the detailed description of the chief complaint to understand the symptoms and course of the disorder. Listen and question, then write down orderly sequence that makes sense to you. So, as the time sequence, when and how fast, what order did event occur, frequency or intermittency, location, laterality, severity, associated symptoms, or documentation or old record of the patient or photos. Still under the history of present illness, we have some example of disturbances of vision such as blurred or decreased central vision, decreased peripheral vision, which is seen in patient with glaucoma, altered image size, diplopia or double vision, floaters, photopsias or flashes of light, and iridescent vision or halos or rainbows. Ocular pain and discomfort. Examples are foreign body sensation, ciliary pain, photophobia, headache, and asthenopia or eye strain. Abnormal ocular secretion like lacrimation or excessive tearing, and epiphora or spilling of tears onto the face, and dryness and discharge. For abnormal appearance, examples are ptosis or drooping of the eyelid, proptosis or exophthalmos, misalignment of the eye, redness, opacities, masses, and anisophorias. For the past ocular history, it is important to ask the use of eyeglasses or contact lens, use of ocular medication in the past, ocular surgery, ocular trauma, and history of amblyopia. Ocular medication is asked to know how the patient responded prior to therapy, or recent medication can affect the patient's present status. General medical and surgical history. Many ocular diseases or manifestations are associated with systemic diseases like hypertension, diabetes, TB, or thyroid disease. And for ophthalmologic examination, visual acuity measurement is a fundamental element of basic eye examination. It should be performed prior to any manipulation of the eye. Ensure that the visual acuity chart is well illuminated. Visual acuity testing is usually performed with the aid of Snellen chart. Each eye should be tested separately, both with and without correction or spectacle. Test is performed at a distance of 6 meters or 20 feet. So if the patient is unable to read the largest letter, move the patient closer to the chart. If the patient cannot read the biggest letter at 1 meter or 3 feet, proceed with counting finger. If the patient is unable to count the extended finger correctly up to 1 foot, then next is hand movement. Determine if the patient can distinguish the presence or absence of hand movement. Light perception if the patient is unable to correctly identify the direction of light source. And no light perception if the presence of light cannot correctly detected by the patient. When taking the distance visual acuity, we need a Snellen chart, plane occluder, pinhole occluder, and flashlight. Pinhole acuity testing is if the patient visual acuity improved by 2 lines or more, then we consider error of refraction. We use a Jaeger chart in near visual acuity testing. It is performed at 14 inches distance. It assesses the ability of the patient to see clearly at a normal reading distance. Near visual acuity usually recorded both the size and distance of the smallest that the patient can read correctly. Example, J5 at 14 inches. For pupil examination, assess the size and shape of the pupil, the reaction of the pupil to near and light, and swinging flashlight test. For pupil exam, it is usually examined in a dark room and ask the patient to fixate at a distant target and shine a light on both eyes and observe for the size of the pupil. The normal size of the pupil is 2 to 4 millimeter. If there is a size difference of 2 millimeter in pupil size, it is considered abnormal. And adhesion between the iris and the lens or synechia can lead to abnormalities in pupil shape. Reaction to near to evaluate the accommodative ability of the pupil. Observe the size of the pupil as the patient shift focus from a distant to a near object. So the normal response is the pupil will constrict with accommodation. For light reflex test, we test for direct pupillary reaction. There is a brisk constriction of the pupil upon shining of light directly on the patient's eye. And for consensual pupillary reaction, there is a brisk constriction of the contralateral eye. For swinging flashlight test, it is performed by shining a light on one eye, then swinging the light to the opposite eye. So, swinging flashlight test is used to evaluate for relative apparent pupillary defect or REPD. If there is positive REPD, we think of optic nerve lesion on the side of the dilating pupil. For the normal pupil findings are recorded as equal and briskly reactive to light, or pupil equal, round, reactive to light and accommodation. And if there is presence of or absence of REPD. For the external eye examination, check for the skin if there is erythema, nodules, or vesicles. And for eyelid, if there is ptosis, entropion, or ectropion. And for the lacrimal system if there is a lacrimal mass. Ocular motility testing, examination of eye movement begin with examination of ocular alignment in the primary position or straight gaze. So the simplest method is to observe for the position of corneal light reflex. So instruct the patient to look straight and fixate at a distant target while light is shown toward both eyes. A reflection of light should appear at the center of the pupil in both eyes. And if there is misalignment of the eye, there is the corneal light reflex is outside the center of the pupil. Example, the patient has esotropia or the eye turned inward, the corneal light reflex is displaced temporarily. For ocular motility testing, instruct the patient to keep immobile as he or she follows your finger. Use a pen light or small target with his or her eyes as you trace the letter H or a six-armed star. For intraocular pressure, we use the applanation tonometry, and it remains the gold standard for IOP measurement. So IOP is considered normal if it falls within the range of 10 to 21 millimeter mercury, or if the difference between two eyes does not exceed 2 millimeter mercury. Slit lamp biomicroscope, it facilitates examination of the anterior and posterior segment of the eye, which includes the eyelid, sclera, conjunctiva, iris, lens, and cornea. For fundus examination, we use direct and indirect ophthalmoscope to assess the posterior segment of the eye, especially in patients with systemic illness that can affect the retina, such as hypertension and diabetes. So there are 5 structures that should be observed in a systematic fundus examination: the ocular media, the optic disc, the retinal vessels, and retinal background and macula. So for ocular media, check for or observe for the presence of ROR or red-orange reflex. ROR indicates the clarity of the media, the ocular media, the cornea, the lens, the aqueous and vitreous humor, and condition of the retina. For the optic disc, take note for the color, shape, and margin. So this is a photo of a normal disc showing a healthy neuroretinal rim with distinct disc border with cup-disc ratio of 0.3. And this is a photo of a tilted disc seen in myopic patient. And this is optic disc with neovascularization seen in diabetic retinopathy. And this is a picture of this with blurred margin or optic disc edema. And in glaucoma, there is an enlargement of the cup. It is seen in glaucoma. And it is important to evaluate the course, the caliber of the retinal vessels, note for pigmentation, lesions, or abnormal hemorrhage, exudates in the retina and macula. For Ishihara testing, it is a color perception test for red-green color deficiency. We use Ishihara plates. For full test, it consists of 38 plates. And lastly, the Amsler grid. Amsler grid is a square-shaped grid used to detect or monitor metamorphopsia, scotoma involving the central vision. And for summary, acquiring the skills to be able to perform the basic eye history and ophthalmic examination will allow physicians and allied health workers to recognize potential vision-threatening condition. And that's all. Thank you.
Thank you very much, Dr. Gabrielio, for that very informative lecture. So for any questions, you may type it in our chat box below, and we will be answering them at the end of the program or at the end of all the lectures. So also remind everyone to please fill up the speaker evaluation form on the chat box. Now to introduce our next speaker, may I call on Dr. Pajarillo, sir?
Yes, thank you, Paula. So for our next speaker is graduate of the St. Louis University in med school, no? I think with honors yata to. And he's a graduate of ITRMC. She was actually the first graduate of ITRMC to have a fellowship at the UPPGH, no? Pediatric Ophthalmology and Strabismus. She is currently the residency training officer and chief of the Pedia Opta Service. So may we welcome everyone, Dr. Ruth Peña, and her topic will be on pearls for an efficient OPD consultation and the e-consulta. Dr. Ruth? Wala yatang sound, Dr. Ruth? Walang sound. Walang, no audio.
Yan po, sir. Okay na po.
Good.
Thank you. Excuse me, disabled yung participant sharing. Okay lang ba na i-enable?
Maki, can you make
Okay na.
Ruth the co-host?
Thank you. Okay na ata. Okay, good morning. So my topic would be pearls for an efficient outpatient consultation. So kung alam nyo na gawin lahat yung lecture ni Mela, so baka pwede nyo nang palitan na rin yung doctor. Or kung sa history pa lang, alam nyo na yung treatment ng patient. So if you have a efficient or fast doctor, the OPD flow would be fast. But if you have an efficient staff, mas mabilis na naman. Okay? So there are three parts of the outpatient consultation: the outpatient reception, the consultation proper, and the disposition. So for the outpatient reception, so this would involve the staff and the patient. Okay. So what are the roles of the assist to facilitate the consultation, the reception? Okay. So first is to determine the patient data. So dapat complete ito, lalo na yung age at saka kung minsan yung occupation kasi may data na makukuha sa occupation regarding the case of the patient. Next, we have to complete the vital signs, lalo na sa ITRMC kasi kung kulang yan, may CAR na naman sa ISO. An important thing to do is to note the chief complaint. So, pwede naman diretso sa doctor na siya nang magtanong. Pero kung tatanungin ng staff ito, the staff would have an idea on what to prepare, and kapag nakita din ng doctor yung chief complaint, parang may idea na siya how to go about the consultation, kung ano yung meds, ano yung process, etc. So for the chief complaint, kapag na-determine nyo na may history of trauma, kaya may pain, tearing, at saka may redness yung eye ng patient, pwede tayo mag-instill ng anesthetic drops. Okay, so ito ang anesthetic drops. The most common anesthetic drops used para sa Philippines ay itong proparacaine or alkane. So when we instill the drops, Dapat itong tip hindi magta-touch sa lashes at saka sa eye para hindi ma-contaminate yung bottle, yung laman. Tapos, ang instruction sa patient, pag anesthetic drops, pagkapatak, mahapdi, so the patient has to close the eyes for 10 to 15 seconds hanggang mamanhid yung mata. So, kailangan i-instruct yung patient para hindi siya magulat, para comfortable siya, at alam niyang i-expect niya. Okay? So, pwedeng ipatak ito para may hindi mag-complain yung patient na naghihintay sa OPD. Okay. The next thing to take is the visual acuity as lectured by Dr. Gabrilio. So, pwedeng gawin ito ng doctor. Pero kung gagawin ito ng staff, so mas mabilis na naman yung flow. So, bakit important ang visual acuity? So, kung poor ang vision ng one eye, so at hindi nagtutugma doon sa findings ng doctor, alam niya kung anong hahanapin niya pa. So, ito yung mga 4 na important na gagawin ng staff para ma-facilitate yung reception ng patient bago mag-proceed sa consultation. Okay? So this is the visual acuity test. One eye at a time is tested, and usually distance visual acuity ang unang measure. Okay, so for the outpatient consultation, involved ang doctor at saka patient. Kung minsan, lalo na kung efficient yung staff, tumutulong siya. So kapag nandun yung staff na nag-a-assist, mas mabilis matapos ang consultation. So what is the role of the assist? First is to check the materials and the equipment. Okay? So first is to check the slit lamp light. So this is the slit lamp. Ito yung pinaka-importanteng equipment ng ophthalmologist. So bago mag-start, check yung light. Ito yung switch kasi kapag hindi siya umaandar, matagal maghanap ng bumbilya. So minsan hindi alam i-install. Okay. Next is to prepare the cotton buds, tissue, alcohol, eye drops, press pad. Dapat kompleto na yan sa table, pati ballpen, nagsusulat para mabilis ang flow. Other things to prepare are the lenses and the indirect ophthalmoscope usually, or kung may iba pang gamit yung doctor. So these are the condensing lenses. Yan, condensing lens. Ingatan ang magamit na to kasi mahal sila. Ito ang indirect ophthalmoscope. Ito ay gagamitin kapag nag-dilate or nag-examine ng retina yung doctor. Okay. So after checking the materials and equipment, you should position the patient at the slit lamp. So paupuin niya na, i-adjust na yung chair. So ito yung slit lamp. You should check for the height of the chair. Dapat hindi nakakuba yung patient or hindi naman nabibitin yung ulo sa may slit lamp. And you have to place the chin and the forehead on the forehead rest. Dapat itong chin nakababa dito, itong forehead nakadikit sa forehead rest. So important yan para ma-examine ng tama. And the lateral canthus should be aligned with the marker. So this is the lateral canthus. Itong side ng eye, naka-align dito sa marker. Ito yung black part. Minsan arrow, minsan white. Ito ang marker. So dapat nakaposition na yung head dyan. Kung i-assist ng nurse yung patient, mas mabilis tapos din ang examination. The next role of the assist is to know the eye drops. Dapat naka-prepare din sa side. So these are the anesthetic drops. Itong most commonly used. Proparacaine. This is the dye or the fluorescein. Dye kapag naka-dissolve itong strips doon sa loob ng eye drops. Or ito yung fluorescein strips kung mas mayaman yung doktor. Ito yung pwedeng idikit na lang doon pagkatapos instill yung anesthetic. So this fluorescein strips or the dye is used to look for abrasions or defects sa cornea. Okay? So kapag may trauma or kapag may masakit, nakapikit yung patient, yan, naka-ready na yung fluorescein strip ninyo or yung dye ninyo. And these are the dilating drops. This is the most commonly used. Itong Sanmid, pwede rin yung tropicamide, yung red yung cap. So this is used to dilate the pupil when the doctor would examine the retina. Okay. So for the outpatient consultation, we have to know the common outpatient procedures so that we could assist the doctor and maibigay yung mga needed equipment at saka materials. So first common measuring procedure is measuring the intraocular pressure. So kung na-elicit nyo na sa chief complaint na may glaucoma yung patient, alam nyo nang ine-measure yung IOP niya. So ito ang IOP measurement. Yan. So nakadikit itong applanation tonometer na nakamount sa slit lamp doon sa eyes at saka may blue na light. So kapag may blue na light, kailangan ng dye at kapag may nakadikit sa mata, kailangan ng anesthetic. So naka-prepare, anesthetic, at saka dye. So kayo na rin magpapatak niyan kung mag-a-assist kayo. Okay? So another common procedure is the removal of a foreign body. Okay, so yan. Kapag gagawin yan, lalo na kapag gumamit daw ng grinder or nag-welding, what do you need to prepare? You will need anesthetic ulit kasi hahawakan yung eyes. Kailangan ng dye or fluorescein strip para makita kung may sugat, yung cornea. Other materials needed would be cotton buds, pantanggal ng puwing sa lid, forceps, and a 1cc syringe or needle para sa pagtanggal ng foreign body sa cornea kung ayaw sa cotton buds. So, ang important dito din ay kailangan yung hawakan or so itulak yung likod ng ulo ng patient, lalo na yung mga tatanggalan ng metallic na foreign body kasi sila yung takot, magalaw, gumagalaw yung ulo, inaatras yung ulo kasi natatakot sa needle. Okay? So, kapag efficient yung assist, hindi gumagalaw yung patient, tapos agad ang procedure. So another outpatient procedure would be the dilated examination. So itong dilated exam, this is needed to view the retina and nerve, so yung loob ng mata. Okay, so ito ang dilated pupil. Huwag niyong ipapa-IO sa doktor niyo na ganito kalit yung pupil. Kung masungit siya, magagalit siya. Okay, so this is what we see inside the eye kapag dilated na yung pupil. Okay, so how do we dilate the patient? So kapag sinabi ng doctor, dilate mo, sabihin nila, so we have to instill tropicamide. Tropicamide, yung Sunmid or yung red ang takip, 1 drop every 5 to 15 minutes until pupils are dilated. So yung iba, 1 drop lang, magda-dilate na after ilang minutes. Pero kung gusto ng doctor na fully dilated or malaki yung maximum ang dilation niya, 1 drop every 5 to 15 minutes times 3 doses. Tapos hintayin nyo mga 30 minutes, 40 minutes, dilated na yun. Kapag hindi masyadong nag-dilate, pwedeng yun na yung maximum dilation ng patient or pwedeng kung bata siya, naiiyak niya yung drops. Okay? So, what do we prepare for the dilated exam? The dilating drops. So, yan ipapatak. And the materials needed would be the condensing lenses, itong pansilip sa retina, tsaka itong indirect ophthalmoscope. So for the indirect ophthalmoscope, this would need this big lens here, the 20D lens or the 28D lens. Yung maliliit, ginagamit sa slit lamp. Okay, so this is usually done in dim light. So kapag nilabas na yung lens na ito, sinuot na yan, patay na yung ilaw, pero may mga doktor naman na okay lang kahit na maliwanag. Pero kung pinatay nyo yung ilaw, mas may impress ang inyong MD. And this can be done while the patient is sitting or lying down. Yung iba, hindi maarte, pwedeng sitting down or mabilisang examination lang. Kung masinsinang IO, kailangan lying down. So dapat nakaprepare din yung examination bed. Kung bata, nakaprepare yung kumot na pang mummify plus yung lid speculum na pang bukas. Okay? So, how is dilated fundoscopy at the slit lamp done? Ganyan, nakaupo yung patient, may light dyan, nandun yung condensing lens. So ito, important ulit na itulak yung head kasi umaatras ulit sila sa bright na light. And this is indirect ophthalmoscopy. Yan, nakapasilaw din mga yan. Kaya kung magalaw yung head, pinapahiga yung patient. Okay. So for the outpatient disposition, tapos na ang consultation, what is the role of the assist? It is to check the prescription and the instructions. Kung minsan, namimiss ng doctor yung kung ilang days, kung ano yung frequency, kung anong number ng bottles, etc. So, i-check ito. Tapos kung may tanong yung patient regarding the frequency of installation of drops, yung follow-up, i-check na rin ng assist. At madalas, kung minsan, kung takot yung patient sa doktor, sa nurse tinatanong or sa assistant, sa secretary tinatanong. So you have to know how to explain the prescription, instructions, the follow-up. And it is also the role of the assist to check for the completeness of the chart or the record. Sa ITRMC, dapat kumpletong record kasi hindi matatandaan ng doktor kung ano yung findings niya ng last check-up at saka makakar na naman sa ISO kapag kulang. Okay? The next is to log. Kapag may logbook, log na siya or sulat yung next schedule niya for follow-up. Pero madalas kapag opta, lalo na ngayong pandemic, before check-up yung scheduling. Okay? Pero mga ito kailangan tapusin. Okay. So what to do if the OPD closes again? Bagong variant, lockdown ulit ang OPD. You have to advise the patients to look for ITRMC online konsulta sa internet. Okay, so yan, K. Hahanapin nila yan. So kailangan meron silang watcher na alam gumamit ng cellphone or internet. Okay, so ito ang role ng assistant dito ay advise yung patients kung paano gamitin kasi hindi naman kayo ang sasagot sa online konsulta. So, anong laman ng ITRMC online konsulta? So, they would click on this link. So, itong www.doctor.itrmconline.com. So, maganda na ipakita nyo ito sa patient. Kunwari, parang contingency plan lang kung online konsulta na lang yung follow-up niya. So, to click on this link, and kailangan tandaan ang registration code. Okay? So, ngayon, kapag may click pa na link na dapat piliin yung department, so, i-remind niyo ng ophthalmology yung pupuntahan. Okay? At tandaan yung registration code. Follow the instructions, kausapin ng doktor, etc. Okay? So, what are the ITRMC online consulta tips for patients? So, itong role ng staff na sabihin sa patient kung ano ang gagawin doon kasi marami sa kanila ang pasaway. Okay, so tandaan ang schedule ng online konsulta. So Monday to Friday lang, 8 to 3. Maraming patients ang nasasabi, Sabado nag-login, nag-click ng link, past 3 na or 6:30 pa lang. So you have to instruct them na Monday to Friday lang, 8 to 3. Okay, so huwag kalimutan ang registration code. Kung hindi nakatype ang yung registration code, hindi kayo aasikasuhin. You have to remind the patients of that. Tapos, dapat present ang patient habang ongoing ang online konsulta. So, yung ibang mga patients, ay nasa kapitbahay lang po ako, babalikan ko yung pasyente sa bahay. So, matatagalan, hindi na matatapos ang online konsulta. Okay, so tandaan or alamin ang mga gamot na pinapatak. So bago magpakonsulta, dapat naka-prepare na yung eye drops, lalo na kung glaucoma, maraming mga patak yan. Kasi pag tinanong ng doktor kung ano yung mga current na pataks, na mga patak niya, di kailangan instant ang sagot. So next, ihanda ang mga picture for uploading. So bago pa magpakonsulta, mas magandang na-picturean na yung mata. Kasi kung wala yung patient doon, or i-upload or pipicturean pa lang during the online konsulta, hindi na naman matatapos. Okay, and you have to remind the patient na sumagot agad sa mga tanong ng doktor. Okay. So what are the tips for the patient for uploading the eye picture? So bago naman mo yung patient, sasabihan nyo na kung paano mag-picture. So ganyan, dapat kaganda, pero feeling ko magandang camera nito. Okay, so shine a light from the sides of the eye. So dapat nandito yung flashlight, malakas na ilaw, cellphone flashlight mula dito sa side. Yan. Tapos, take the shot from in front of the eye. Hindi ko alam kung parang mas maganda ata walang flash, basta maliwanag yung flashlight sa side. And the details of the eye should be seen. So dapat kita yung lashes, yung eyelid, yung sclera, yung pupil, yung cornea. Okay, so this is my last slide. Time is up na ata. Thank
Morning,
you.
boys. How are you?
So, thank you, Ruth, for that very clear, concise, and very practical. I'll wait for your milk tea reward. Oh, okay. Thank you, Ruth. So, we're reminding the audience to fill up the speaker evaluation form. We will entertain your questions at the end of the program. Okay, Paula.
Thank you, sir. So for our next speaker, he is a graduate of the University of the Philippines College of Medicine. And he took his residency training in ophthalmology at the UPPGH Department of Ophthalmology and Visual Science. He had his fellowship in medical and surgical retina at UPPGH and Rotterdam Eye Hospital in Netherlands. He is the vice chair for research and is currently our retina service head consultant and former chair here in ITRMC Ophthalmology. He's also a clinical associate professor and a vitreoretinal consultant at UPPGH. He is also a board member of the Vitreoretina Society of the Philippines and a member of the Philippine Academy of Ophthalmology and PAO Northern Western Luzon chapter. So his topic is all about overview of the ITRMC Eye Center. So I'd like to call on again Dr. June Pajarillo for the next lecture, sir.
Yes, thank you, Paula, for the introduction. So good morning again, everyone. Can you hear me and can you see my slides?
Yes, sir.
Okay. So I will be talking about the ITRMC Ambulatory Eye Center. As you can see, there are three components of the eye center. You have the OPD, the surgical center, and the eye instrument center. So all of these areas are integral to our goal to be an end referral center, meaning we manage, excuse me, the most diverse and most complex of cases in ITRMC. And by far, the EIC is the most expensive part of the eye center. The slides are not moving. Okay. So the EIC or the Eye Instrument Center has a vast array of services, just like a menu where you can pick what you want to eat. The services offered ranges from different highly specialized diagnostic tests, laser procedures, as well as ancillary tests. All these tests are used for the care of the patient. The objectives of my talk is not to teach you how to use all these machines, but just to give an overview on what these machines are used for, what they look like, and probably some practical tips, just in case you will be assigned to this area. So this is the current EIC. So kung nakikita nyo, it's a big open space area with all our toys around. Shown here is Ma'am Iso, Ma'am Isobel, our one and only ophthalmic technician. So she is in charge of all these instruments. So you can just imagine how demanding her work is. So she works both with the full lights on and sometimes in the dark, using these different machines. Okay. So wait. I will begin my after the overview. I will begin my talk with a case. I won't be focusing on details about disease and management, but I will try to make you appreciate the role and relevance of the EIC in the patient's journey. So we have here, the slides are not moving. We have here Aling Nelly, a 56-year-old female government worker, diabetic, hypertensive, complained at the OPD. In our OPD, na malabo yung kaliwang mata. As you can see here, she has a thick cataract, mature cataract. And the plan was to remove the cataract, and but before that, we need to do an ultrasound as well as a biometry and keratometry. So these are the things that this was the menu presented a while ago, and we have all of these tests. For the ocular ultrasound or B scan, so why do we need this for Aling-Nelly's case? So it's used to evaluate the vitreous and retina in cases of opaque media. In Aling-Nelly's case, we have the cataract, no, meron siyang cataract, so we need to evaluate the retina and vitreous to determine if there are any problems, no, before doing cataract surgery. So the principle of ocular ultrasound is basically uh, differential echogenicity, so sound waves reflecting back to the probe and to the machine. This is usually done by the ophthalmologist and not the ophthalmic assistant or the technician. And on your right is the machine, no, showing this is our machine at ITRMC, and below is a sample of the scan. So what should I prepare? I think this will be discussed further later, but just showing you what we need during an ocular ultrasound. And usually, the best way is for the patient to be supine, nakahiga yung patient, and you see the probe and the sonologist, no, in front of this screen. So for ease of use, that's the best position for doing an ocular ultrasound. Okay. So Aling-Nelly underwent an ultrasound and results were normal, and we proceeded with cataract surgery. But before doing cataract surgery, we will need a biometry and as well as a keratometry. So just a review, no, for us to have good vision, the light refracted should fall on the retinal surface, no, exactly at the fovea. So pag lagpas or kulang, malabo yung vision natin. So in the same way, if we replace the normal crystalline lens with an intraocular lens, kailangan yung focus ng IOL na yan will be precisely on the surface of the retina. So may specific power for each individual yung IOL. We compute it. So biometry, or we termed it also as A-scan, is used to calculate the power needed for intraocular lens implantation. So the principle is just like your ocular ultrasound. It uses ultrasonic or sound waves, but newer models uses light. So it measures distances between the eye. So this is usually done by a trained technician or an ophthalmologist. You see here above is the optical biometer and below is the ultrasound biometer. And this is the formula we use to calculate for the power of the lens. P is the power. So one part here in the yellow, pink circle is labeled as L. That's the length or the axial length of the eye, which you can measure using the biometry. So this is just an example of a biometry scan on the right. This is what we get. And these are the things that we should prepare. Okay. For keratometry, this is the best friend of your biometry. No? Palagi magkasama to. Pag nag-order ka ng biometry, you will need a keratometer. So this is used to measure corneal curvature needed for IOL calculation. As you can see here, no, dito sa SRK2 formula, may K dyan. So yan yung value na nakukuha sa keratometer. So you will need to plug this in to get the power of the intraocular lens. Shown below on your right is the these are our machines at the EIC. No? This is a keratometer, an ancient keratometer, manual keratometer, and this is an automated keratometer. So both will work fine. So Aling-Nelly underwent an eventful phacoemulsification, no? Implanted with a 21 diopter lens. However, post-op vision was not good. As you can see, it's only 2400. We examined the retina. We examined the retina, and what we see here is numerous hemorrhages and exudates. So we diagnosed her to have diabetic retinopathy. So she will need another test, no? Two tests, Fluorescein Geography and optical coherence tomography. So medyo namamroblema nun si Aling-Nelly, kaka-opera pa lang, meron na naman gagawing test. But luckily, we have this test at the Eye Instrument Center. And for fluorescein angiography, you can see here the photos. We inject dye, fluorescein dye, through a vein, no? Usually antecubital area. That dye will go to the eye and we'll take photos. So that's the usual procedure for this. And this is used to evaluate the retina and choroidal vessels. usually in cases of diabetic retinopathy, AMD, or retinal vein occlusion. So it uses dye, which fluoresces, wherein we can see the retinal vessels more clearly. So this is usually done by the technician, but the dye is injected by the nurse or the MD. So just some warnings or some precautions when you do fluorescein angiography. There is a very small risk for fluorescein anaphylaxis, meaning you need to do a skin test. There should be a standby e-cart and be ready to call an MD, no? But not your IMD. Walang alam ang IMD pag emergency na ganyan. No? So call your IM or FAMED who is nearby. Number two, be wary of pregnant patients as well as patients with kidney failure, and make sure to tell your patient that the skin can or urine can turn yellow. They can feel pain from the needle prick, and some would have nausea and fainting. No? So we need an informed consent form to before we do this procedure. Okay, this is an example of a fluorescein angiography. So these are some tips to get excellent FA images. No? So what's important here is those in pink. We have to have maximal dilation, and you have to know the photographic sequence and timing. So this is a time procedure, very important in time. You have only a few minutes to complete the entire examination. Otherwise, the dye is already gone. You won't see anything. So, but you only have to take necessary photos. Hindi naman trigger happy kasi sobrang lakas ng flash ng light. Okay. For macula OCT, optical coherence tomography, just a review, the macula is located at the center of the retina. It's just a small portion here in the big yellow circle. So OCT is used to evaluate the histologic macula. This is used for diseases usually due to macular edema of various causes. The principle is using light instead of sound waves, and this is done by a technician. So this is just an example. No? Above upper left is the H&E histologic section, and below is your OCT scan. So it's very, very remarkable. No? You don't need to cut the eye open to get histologic sections of the retina. So we have this at ITRMC. This is just an example of a scan using our Heidelberg OCT. And the important thing is to incorporate or input the accurate age of the patient. The values here are age match, so we have to input the correct age. But most of the functions are automated, no? Unlike your FA where you need so many preparations. For OCT, it's pretty much simple. So after the test, Aling Nelly was diagnosed to have proliferative type, meaning there's neovascularization, and she would need PRP. So mangyak-yak na si Aling Nelly, meron na namang procedure na kailangan gawin. Well, the machine is readily available in our eye instrument center. This is what we have. This is a LightMed 532 nanometer laser. So the indications for doing laser is for primarily for neovascularization and ischemia, and other indications as well as seen here. The principle is using thermal energy, usually at the 532 nanometer range or sometimes at the 810 nanometer range. And this is done by the ophthalmologist or the retina specialist. So this is a video showing the procedure. So just a few warnings or precautions again. The lasers are harmful. So there's backscatter. You can see the green light. So you have to make sure that the area is shielded, and for those inside the room, they should wear goggles. The procedure is also painful, and after the procedure, patients would complain of a temporary visual impairment. And also, the last was to take care of the lenses because the lenses are very expensive. So what should I prepare? This is in pink is the most important. The ICF, you have to dilate. So remember procedures which you need to dilate and which other procedures you need to constrict. And you have to prepare the field health requirements. Okay, so Aling Nelly underwent PRP and anti-VEGF injection. Anti-VEGF injection is done at the OR. So on follow-up, Aling Nelly had increased IOP. The disc looks large and very shallow anterior chamber, as you can see in the slit lamp photo. So she was diagnosed to have angle closure glaucoma and would need the following test again: perimetry, OCT, and would undergo laser iridotomy. So, well, we have all these machines to do all these procedures. So Aling Nelly is quite lucky. So this is just an example of a perimetry. We do it under dark illumination, and this is a visual field. So it's used to map out deficits in the field of vision, uses for glaucoma, and we project lights at various areas not to map out areas which are compromised. So this is done by technicians as well. So in producing reliable visual fields, we need in pink na yung most important, we have to have a manifest refraction and make sure na do not dilate patient. When you dilate, hindi papabalikin yan on some other day. So this is an example of an optic nerve head OCT scan using our Heidelberg. It's basically the same concept as your macula OCT. For YAG iridotomy, this is our machine. I'm not sure. It's light med. So it's used to create an iris hole. Indication is for narrow angles or close angles, just like our Aling Nelly. And it uses the neodymium YAG laser. So this is another laser that we have in our EIC. So this is usually done by the ophthalmologist or the glaucoma specialist. This is a photo of a YAG hole, a hole done using a YAG laser. And we have to constrict patients, no? Unlike your PRP, you will need to dilate. And again, prepare your ICF and your field health forms. So Aling Nelly underwent laser iridotomy, pressure was controlled, we went back to Bicol and was lost to follow-up until, again, suffered from the ring of vision. As you can see on the right photo, this is an after cataract or a PCO, posterior capsular opacity. So again, feeling helpless, but tanggap na lang, kailangan niya mag-undergo ng other procedures. Buti na lang ulit, meron tayo sa EIC. So this is the same machine used for YAG iridotomy. So we call the procedure YAG capsulotomy, basically to create a hole at the capsular opacity to clear the visual axis. Indications, as I've said, for after cataract, and the same machine is used, and it can be formed by any eye doctor. So what we need to prepare, as enumerated here, this is the lens that we use. When we compare it to the other lens, this is the lens we use for iridectomy. No? So meron parang naka-elevate, naka-umbok sa portion na yun. So do not mistake the lenses pag inabot sa doctor. So a few more slides, 3 or 4 slides. So maximizing the life of equipment. So you have to read the manual, request for a product demonstration, maybe observe experienced technicians. You have to follow preventive maintenance schedules and avail of service contracts. So there are service contracts, para hindi ka na problema on how much you will spend for maintenance as well as repairs. Of course, you have to check the warranty. So you have to ensure stable electricity, use high-end UPS. Hindi lang simpleng UPS, dapat yung mga malalaking UPS, mamahalin kasi yung mga instruments na to, no? Also for your ABRs. And you have to immediately report problems. You have to document the error message. You can take photos and inform the technician, the supplier. And try not to do too much troubleshooting. These are very expensive equipment. Baka mas marami pang masira. And do utmost care in handling, cleaning, and storing this equipment. Okay. So for assisting during laser procedures, probably this will be discussed later. So in short lang, you have to document, fill up the ICF and the field health forms. You have to prepare the patient, know when to dilate, know when to constrict, and you have to time it, no? Kasi minsan matagal yung doktor, wala nang effect ng medications. You have to prepare the machine. So some machines would require warming up, booting, which will take time. You have to prepare the needs, depending on the procedure, and you have to immediately report malfunctions para yung susunod na gagamit, alam niya na sira or naayos na. And you have to know who to call. And for laser, beware of backscatter. So you use protective goggles, close the door, place danger signs around the area, and work with a sense of urgency. So last two slides. So our eye instrument center is actually a heavyweight. No? We are complete. No? We can manage a vast array of diseases. The patient does not have to go out of ITRMC. So we're very lucky na the administration is very supportive, and we've accumulated all these machines through years. Hindi naman to sabay-sabay binili, pero through the years. But behind this is the brains. Okay, so we are a very small department. It's still very important, no? Even if we have the most sophisticated machines, we need someone to use them properly. And we are undermanned, and we need all the help that we can get, especially for the EIC. Okay, that's my last slide. If you have any questions, you can ask it at the end of the session. Thank you.
Thank you. Thank you very much, sir, for giving us an overview of the eye center, instrument eye center. So again, reminding everyone to kindly fill up the evaluation forms for each speaker on the link provided below. So for any questions, again, you may type them in the chat box and we will answer them at the end of the program. So again, to introduce our next speaker, may I again call on Dr. Pajarillo?
Thank you, Paula. So for our next speaker, she's a graduate of the UP College of Medicine. Took his residency and glaucoma fellowship at the UP PGH as well, and is currently a glaucoma service consultant at ITRMC and is part of the hospital research team. So without further ado, Dr. Patricia Concepcion will be talking about EIC, workflows, and pearls in maximizing efficiency. Dr. Patricia.
Morning.
Good morning.
Can you see my slide?
Yes, slides are okay.
Okay. So, good morning again, everyone, and thank you for all those who have been attending the Ophthalmic Support Staff course. And again, I'm Dr. Patricia Ann Concepcion. Today, I will be talking about the workflow of the ITRMC Eye Instrument Center, or the EIC, and how we can maximize efficiency. So, the EIC is essential to any eye center aside from being able to help in the diagnosis and management of the patients. It is also a large contributor to the revenue of any eye center. So it's important that we utilize our diagnostic and laser machines. Okay, so I have no financial interests in any of the products shown in this presentation. And these are the objectives of this discussion. Okay, so I won't be discussing all of the laser machines, but Dr. Pajarillo was able to show them earlier. No? But first, it's important to be familiar with the machine. So we have the diagnostic machines and the laser machines. The diagnostic machines are usually accompanied by computer screens, as you can see here. And they can be used by the support staff or the doctors, but they should have been adequately trained to use them, no? And most of the time, it is the support staff that gets the training to operate the diagnostic machines. And then here are examples of the laser machines. And they look like slit lamps with attached consoles that these are where the settings for the laser will be placed. And these, on the other hand, are for therapeutic purposes. Therefore, only the doctors use them, but it's also the role of the ophthalmic support staff to have the needs for the procedure ready and to assist the doctor if required. So when you know the machines, you know the procedures, everything is set and good to go, there should be a workflow in place to ensure fast turnover of the patients and streamline processes. Okay, so here's the general workflow in the ITRMC Eye Instrument Center. So our lovely ophthalmic nurse, Ma'am Isobel, schedules 3 to 4 patients for procedures per day, depending on her availability. And then on arrival, the patient is registered as an outpatient in the hospital system and given an OPD blotter. And then vital signs, visual acuity, and a brief history of the patient are also taken. So while the patient is being prepared for any procedure needs, paperwork is also being prepared, especially if the procedure is covered by PhilHealth. So the companion is asked to bring the papers to the PhilHealth portal or counter. And while the patient is undergoing the procedure, processing of the paperwork continue, and the bill is given to the companion and a copy is attached to the chart. So if the procedure is not covered by PhilHealth, a charge slip is issued after the procedure and payment is made at the cashier. Or if financial assistance is requested, they are referred to the medical social service. Upon getting back the receipt, the patient is given post-procedure instructions, if there are any, and then discharged and given an appointment for follow-up. So let's discuss some of the ways that we can maximize efficiency in each step. Okay, so for scheduling is very important in maximizing efficiency because of the nature of the procedures in the eye instrument center. The procedures can actually be time-consuming. It's not as fast as blood extraction. So procedures like Fluorescein Geography or visual field testing can take as long as 20 minutes per patient, depending also on how cooperative the patient. So the procedures require utmost cooperation from the patient, since they have to keep a certain eye position or focus on a target to obtain accurate or optimal results. And sometimes, the first-timers, yung mga first time na mag-undergo nung ganung test, they would take a longer time to test than the repeat performers. And then the procedures are also operator dependent. So that's also another factor to consider. Your familiarity or your expertise already with the machines and the procedures. And then if you're a staff member dedicated to the instrument center, then you can schedule more patients. However, if you have other tasks in the eye center, like Ma'am Isabel, you have to limit scheduling. So considering all of these, it might be best to schedule longer procedures on a day when you're more free, and easier or faster procedures on the tighter days. Okay, then for registration. So since patients are scheduled, you are expected to be prepared for the patient and for the procedure. So these are things that should be done prior to the patient's arrival. Ideally, the patient's initial charts or their consultation charts should be present and ready. Yung nakapila na sila dun sa table ninyo. So it will be easy to confirm the diagnosis and the procedure to be done. Hindi yung pagdating tsaka palang hahanapin. And then PhilHealth covered procedures require more paperwork than those that are not. But the paperwork is usually standard, including the informed consent, or OR record, or technique, Cf2, charge slip. So they should be ready to be attached to the chart once the patient gets his or her OPD blotter. So don't wait for the patient to arrive, tapos isa-isa pang kukunin yung papers. So have the sets of papers already prepared beforehand. And then the Cf4 is encoded by the resident on duty. So use templates if necessary or if allowed to speed up things. Okay, and then when the patient arrives after creating their OPD blotter, the vital signs and the visual acuity are taken. And in Ophtha, we were taught that taking the visual acuity before doing anything else is very important. So it's a very important skill that ophthalmic support staff members should learn. So visual acuity testing. This was mentioned by Dr. Gabrilio already earlier, but I would just like to reiterate because that's how important VA is. So visual acuity or VA is the measurement of the smallest object a person can identify at a given distance from the eye. So we usually take the distance VA, which is expressed as a ratio or fraction that compares the patient's performance against an agreed upon standard. So the numerator, the number on top, or the first number, is the distance at which the test was performed, or the distance of the patient from the eye chart. And the denominator, or the second number, is the distance at which a person with normal acuity can read the same line of letters from the Snellen chart, which is commonly used. Okay, so for example, a visual acuity of 20/70 indicates that the patient can recognize at 20 feet the line of the letters that a person with normal acuity can recognize at 70 feet. So for the support staff, it's not really about how it gives you a clue on what the patient's problem is, but knowing the baseline visual acuity is actually a form of protection for everyone, because you should know how well or how bad the eye can see before you do anything, just in case a patient complains of having any change in their vision after the procedure. Okay, and then some diagnostic tests and laser procedures need some pre-procedure preparation. So first of all, again, it's your role to ensure that needs are ready near the machine, whether it's you or the doctor who will be doing the procedure. So for laser procedures, you prepare the key to the machine, your topical anesthetic, and then if the machine looks like a slit lamp, again, it's for laser, the doctor uses a contact laser lens such as this. And this uses an eye gel, and also prepare some tissue, and an elbow rest may also be helpful for the doctor. And for diagnostics, the procedure that need the most preparation probably would be Fluorescein Geography, and you should be prepared with the needs like a butterfly IV set for intravenous injection and the fluorescein dye. Okay, and then know which procedures need pharmacologic dilatation or constriction of the pupil, because as mentioned earlier, pharmacologic dilatation or constriction actually take time. So mas maganda kung kunwari na-take na yung VA, alam mo na yung procedure, agad-agad mas-start yung pagdadilate or pagpaconstrict sa kanila. And then, again, you have to know the procedure, because the machine itself cannot be the basis for this, because a single machine may be used for multiple purposes. So for example, the ND-YAG laser can be used for capsulotomy, in which case the patient needs to be dilated, and it can also be used for iridotomy, in which case the patient needs to have a constricted pupil. So this is what we commonly use for dilatation, yung SANMID, and the pilocarpine is what we use for constriction. And also, know which procedures need the patient's refraction. Dr. Pajarillo mentioned this earlier, because some would need proper correction of the patient's error of refraction to obtain reliable results, such as in visual field testing. Okay, and then what about the procedure itself? How can we maximize efficiency? First, make sure you are with the correct patient. It's just like dealing with antibiotics, diba? Yung correct patient, correct meds, correct dose. So same with diagnostic or laser procedures. Make sure you are with the correct patient. And then give clear instructions to the patient. Yun nga, diba? The procedures require utmost cooperation of the patient. So make sure that the patient understands what he or she needs to do during the test, especially if there's an expected learning curve. And of course, do the correct procedure properly. After the procedure, if a patient requires observation, take note of the time that the patient needs to be re-examined. So, tapos isulat na dun sa chart, so that time will not be wasted. Yung alam na agad ng doktor na kailangan at this time, this patient shall be checked. And make sure that everything that needs to be processed is accomplished during this waiting time. And just like the PhilHealth papers, it's best to have standard or template discharge papers ready para mabilis na lang silang makauwi, mabilis na lang makapag-discharge. And you can proceed with the next patient. Then for the companion should be asked to handle the paperwork and payment concurrently while the patient is undergoing preparation and the procedure itself. So aside from the patient na mahihirapan, baka mahirapang makauwi, kaya nila kailangan ng companion with them to the EIC. The companion also would be asked kasi to handle paperwork while the patient is undergoing the procedure. So clearly instruct them on what to do and where to go. And if possible, to be more efficient, create a checklist or a numbered procedure on a small piece of paper that you can print and attach to the chart, and all the papers to avoid any confusion. Yung lahat ng kailangan nilang gawin na step by step, you can put it in a piece of paper na susundan na lang nila. Or baka pwedeng maglagay ng TARP na may procedures on how the processes go. And then, what else can we do to maximize efficiency in the EIC? So make sure that all procedures are properly documented. It may be a good practice to document start and end times for the steps in the workflow, especially for beginning centers wherein you would like to find out where the process can get slow. And later on, having a proper census on the procedures can help in identifying which machines and procedures had been the most utilized, and this information can be used to further develop the eye center. Then release results in a timely manner. So that may be out of your hands already, but go ahead and follow up those doctors who need to give you those reports. Kulitin nyo lang sila so that you can release your results on time. And know how to properly care for your equipment. Read the manuals. Machines that are well maintained will, of course, give you less problems. And also include how to disinfect the lenses. So sometimes the doctors forget to disinfect the lens. So you should be able to help them and disinfect the lenses as well. So I'll say it now, it's not recommended to use alcohol to clean the lenses kasi baka it's the easiest to reach. Disinfect na lang with alcohol. So it's not really recommended. It's better pa to disinfect them with a mild or diluted dishwashing solution. And this was mentioned by Dr. Paherlio earlier about troubleshooting. So learn just at least the basic no na troubleshooting. So at least man lang for example, if in the middle of
from the patient,
if in the middle of test there arises a problem. So if these are simple errors, then maybe you would be able to fix them as long as they're in the instruction manual. Pero siguro kung wala doon, alam mong wala doon, you should stop tinkering with the machine. And if all else fails, you should know who to contact immediately in case that the machine needs to be serviced. And of course, always be kind and courteous to the patient. So when the environment, when the instrument center is pleasant and conducive, that would make you less likely to commit errors, and that would make the patient more cooperative and make them go back to you. So thank you. That ends my presentation. I hope this lecture had been helpful.
Thank you, Dr. Tricia. No, I'm sure this was a very helpful lecture. No, very many practical tips we all learned from your talk. No, so I will not use alcohol anymore for our lenses. Okay, so thank you again, Dr. Tricia. May we remind everyone to fill out the speaker evaluation forms for Dr. Tricia's lecture, and the next lecture will be introduced by Dr. Paula.
Thank you, sir. So for our next speaker, he is a graduate of St. Louis University School of Medicine and took his residency training here in Ilocos Training and Regional Medical Center. So he is currently the head of the optics refraction service here in our department. So without further ado, may I call on Dr. Charles Angelo Young to talk about the ophthalmology ward workflows and pearls in maximizing efficiency. Sir, Doc Adi?
Okay, hello Paula. Hello everyone. Good morning.
Thank you,
So,
sir.
yeah. Can you see my screen? I shared it.
Yes, sir.
All right. So, most of you at the hospital probably know me already. So, I just say good morning to everyone, and I would like to congratulate all the previous speakers for a very informative and I think a very concise and useful talk, no, that each of them delivered. So this is the last lecture. So basically, we will be tackling pearls for an efficient workflow within the ophthalmology ward. So yun. So this is the outline of my short talk. This is a 15-minute talk. So first, we will be discussing preparing the patient for surgery, followed by tips for post-operative care, and then basic eye nursing care, and lastly, one of the bottlenecks for our services to patients in facilitating the billing, PHIC papers, and discharge. So we will start with preparing the patient for surgery. So again, the overall flow for work in the eye center is very similar to what you do in your other wards, with a few special steps because we are a specialized eye center. No? So the first thing that all of you should look out for are the doctor's orders, including the CP clearances. So although most of our surgeries will be done under local anesthesia, most of them are still seniors and most of them have comorbid. So please do not forget to check the CP clearance of the patients to make sure that all of the recommendations of the clearing physician have been followed. Also follow the doctor's orders on time. So one of the biggest bottlenecks for surgery that we have encountered over the past few years would involve the pre-op dilation of our cataract patients, mostly. No? So they come into the operating room, the pupils are not dilated, surgery is delayed, productivity is delayed, basically. So these are the bullets here are basically some of the things that we should double check before sending the patient down into the operating room. So number one, make sure that the patient has been dilated sufficiently for cataract patients. Ito, ha? And also for our retina patients. If the patient has special cases that may need the intraocular pressure to be decreased, make sure that the anti-glaucoma drugs have been given. So either your mannitol or your acetazolamide. Yes, make sure that they have been given pre-op at the proper timing. Check the IV lines and other special precautions that your subspecialty clinics may require. Double check the paperwork to facilitate the discharge later on. So make sure that the RT-PCR results have been attached. For cataract patients, again, make sure that the biometry measurements have been attached as well. So for yung imaging results for special cases, orbit cases, so if a CT scan is needed or an MRI is needed, make sure that the plates are also sent down with the patient in the operating room. Some patients will be required to be put on NPO. Please make sure that it's been followed, lalo na yung general anesthesia. We do not want to give our anesthesiologist friends a headache as well. And as mentioned by Dr. Concepcion earlier, dun sa procedures niya, always check for laterality. Make sure that you're dilating the right eye, that you're giving the proper pre-op meds on the right eye. So other than that, we also noticed that the supplies are sometimes late or incomplete. So make sure that the pre-op drops, the post-op drops of the patient, as well as the pre-op drops are all complete. So this would usually include the antibiotic drops, the steroid drops, and when available, a topical anesthetic and other miscellaneous supplies, including your IV line, should be complete before you send the patient down to the operating theater. Okay, so a lot of you have not rotated in the ophthalmology wards. So these are just the common drugs that we use to dilate the patients. I did surgery yesterday, the other day, and my yung patient hindi na dilate. But anyway, ayun, Sanmid or intropicamide plus phenylephrine is something we use very commonly. That's what it looks like. So, and in general, any eyedropper with a red cover is a mydriatic or a dilator. So it could be tropicamide plain or phenylephrine. Sometimes there's atropine or cyclopentolate, but you don't usually use that for surgery. Okay. Drops with the green cover are, well, we don't use it too often, but I think our glaucoma cases might need it prior to TRAB. So if you need to constrict the pupil, again, make sure that they're constricted. So, yun, just those drops. Yeah, standard OR protocol should also be followed to avoid any bottlenecks in surgery. So make sure that the nail polish is removed. This has been a recurring frustration for a lot of us. Na delay yung surgery because we could not find any nail polish remover, and it could have been avoided if the patient has been checked before being sent down to the OR. All cosmetics, yung pressed powder nila, yung kanilang little eyeliners, make sure that the faces have been cleaned before being sent down to OR. Dentures will remove jewelry and underwear in some cases. Please just double check all of that. The fourth point here is something I feel is very important. No? Make sure that the patient uses the bathroom na before they're sent to the theater. Have them empty their bladders so they're not straining during the surgery. So a lot of complications can actually be avoided by simply asking them to empty their bladders before going into the theater. Okay, so I think those are the most important pointers or pearls for us to remember when preparing a patient for the theater. Okay, post-operatively, again, it's usually basically a standard procedure for our the patients. Some patients will be required to maintain a certain position. So check your doctor's orders and make sure that the patient follows that, flat on their bed or a moderate high backrest for some cases. Just double check on that. Diet restrictions, if we are able to return their cancel their NPO, or if the IV fluids have run dry, just double check and remove them already. And make sure that the antibiotics and steroid drops are given on time. Most of our drops are given during waking hours only, so when the patient is asleep, you don't need to bother them. What else? Also look out for subspecialty orders, such as patients that have undergone enucleation may require compression dressings. So just check on the dressings that they are not too soaked. You can actually ask the residents to address the problem of faulty compression dressing. Ocular hypotensives when needed in complicated cases. Some cases will also require post-op mydriatics or dilators. So just double check on the doctor's orders basically. And of course, yung laterality you have to check. Okay. Basic eye nursing care, again, there's really nothing out of the ordinary for our patients. One thing I would like all of you to remember is to maintain your minimum health precautions when you are working with the patients. Don't forget your gloves if you can. Don't forget your face masks. And also don't forget to have your patients wear their face masks when you are caring for their eyes. So Other than the usual eye drops, I think two things that I've seen in the ward that may need a little guidance would be our eye patching and the use of eye shields. So, yeah, discharge around the eyes. Just clean them with a damp piece of cotton. Avoid wiping into the globe. So for eye patching, yeah, so I have two pictures here, no? I have seen a lot of patients that have had their eye patches plastered in a haphazard manner. So this will reflect the care that we give to our patients negatively as well. The one on the right, yan, yung medyo diagonal, that's the proper way of plastering your eye patches. So wag ganun ha, wag H, wag vertical, horizontal, iba-ibang direction. So we want to apply the plaster in such a way that the patient won't be in too much discomfort. Okay, eye shields. Yeah, in cases of eye trauma, we use eye shields. That's what it looks like, a plastic thing. So you will notice that the more pointed end is directed nasally. The plaster is also applied diagonally. So, ayun. Yun lang naman. For the last part of this short talk, facilitating billing, PHIC, and discharge. So, a lot of our patients are delayed with their discharge because of incomplete papers, basically. So, as with the other segments and other lectures, if we are able to check everything as soon as the patient arrives, we're able to discharge them quicker. So a quicker turnover will reflect our efficiency and also will increase the productivity of the center, which is our overall goal. So number one, we still follow the standard PhilHealth requirements. So the MDR, the proof of payments, the PBEF are things that we could actually check as the patient is being admitted pa lang. Now for cataract patients, this is something very important right now for our claims with PhilHealth. Make sure that the cataract pre-surgical approval is actually attached and not expired. Okay, double check on the laterality as well. Make sure that the surgical approval matches the eye that has been scheduled for surgery. Post-op, ayan, we check for the signatures. So the patient has to sign this as well as the surgeon. Then charting, the OR records and the OR techniques are all pretty standard. Our nurses are very familiar with this already. So you just check that as well. Make sure that everything has been attached and all the signatures have been affixed. The Cf3 and Cf4 forms are also pretty standard. You're all familiar with this. The Cf4, the residents do this on the computer already. So what you can do siguro is to remind our residents to complete the Cf4 already once the patient has been wheeled into the theater. So as soon as the patient is brought back out, we can facilitate the discharge quicker. Do not forget your tagumbilin and your discharge instructions as well. Again, double check the laterality of the eyes and the timing of the drops. So unless specially indicated by the attending physician, you can tell the patients to just use the drops as well during waking hours. Lastly, for the private patients, we would be having a few private patients as well. Make sure that the PhilHealth, the professional fee forms have been filled out and signed as well. So again, these are all just very short pointers of things that you already know, with a few reminders lang for the off the workflow. And just always make sure that the eyes that you're dropping the meds on are correct. Make sure that the paperwork is complete, and our patients will be the discharge of our patients will be facilitated quicker. Yun lang. If you have any questions, just feel free to ask any of us or the residents. I guess That's it. If there are any questions, bahala na si Paula at si June. Paula, okay na ako.
Yes, sir. Thank you po. So thank you so much, Dr. Young, for that very practical and informative lecture. So again, reminding everyone to please fill up the evaluation forms on our link below on the chat box. So again, for any questions, kindly feel free to type them below. So may I call on Dr. Jun again to please introduce our next speaker?
Thank you, Paula. So we have two more. Actually, Dr. Charles is not the last speaker. We have two more. We invited two more speakers. The next speaker would actually have an overlap with Dr. Charles' lecture a while ago, but this will be on their own point of view, no? And this will cover probably also not only the ward, but also the OR, the eye instrument center, which all utilizes. We need to bill patients and we need to discharge them as well. So for our next speaker, he graduated BS Accountancy at the SLU and is a CPA. Currently, he's Accountant 3 at ITRMC, and he will talk about facilitating patient billing and discharge. So please let us welcome Mr. John Chico. Sir.
Hello, good morning.
Good morning, sir.
Good morning to all of the department, and we are very much humbled that we are invited in this forum. So I would just like to share my screen. Clear po ba daw?
Yes, slides are okay.
Okay, so let me start. So I would like to introduce the team first before I discuss the flow of the billing and claim section. So I am again John Benedict Chico, the head of the billing and claim section. The section is subdivided into 3 units: the billing, the COVID testing claims, and the PHIC claims. And each subunit also has each unit is divided also in its subunits. So the billing has a PHIC billing and a non-PHIC billing. For the COVID testing, the COVID-19 testing claims, we all know that this is now the bread and butter of the hospital since the pandemic. This generating siguro nasa 70% of the revenue for the whole hospital. And the PHIC claims, the regular claims, this is composed of the PPF generation, the claims processing, transmittal, and RTH and denied claims. So let's start. First, ito yung sa admission ng patient. This is the first process. So checking of the PhilHealth eligibility and generation of the PBF upon admission. Ito yung dapat nating the first thing na ma-establish na for patients. Kasi kung wala ito, hindi rin natin makiklaim yung mga procedures natin. So from the start, i-forward sa amin for admitted patient, i-forward. Ang position ngayon ng the PBF team is nandun sila sa first floor ng OPD natin. So lahat ng patients natin, pwede nating dalhin doon or papuntahin doon yung bantay para ipacheck yung PhilHealth. Yung sinasabi ni Dr. Yang kanina with regards to MDR and other documents, kung napacheck na natin yung PBF nila, no need na for these documents. So importante talaga sa atin ngayon na mapacheck yung PBF para malaman kung ano yung requirements na hinihingi. So this is a sample of the PBF form, or makikita na dito kung ano yung ng patient. Yung PhilHealth number, member information, and the patient information. So makikita natin din dito kung eligible to avail PhilHealth benefits. Pag nakita natin na yes, okay na yan, wala nang kailangan. ang mga nagiging problema natin kadalasan dito are the dependents or the undeclared dependents. So kung kailangan ng kunwari ang may PhilHealth is yung asawa and then yung wife or anak ang magki-claim, kailangan natin ng another form which is the PMRF form. Ito naman pagdating dun sa PBF section namin, sinala rin mag-instruct how to paano i-fill up yung form. So mas maganda talaga pag lahat ng patients natin, pati yung mga ina-enroll natin for yung sa CPS, SIPSA, ensure sana natin lahat na mayroon silang PhilHealth para dire-diretso yung process. So, pag okay na yung PhilHealth niya, meron naman tayong another section which is processing the account for non-PhilHealth. So kahit yung mga iba kasing pasyente, kahit may PhilHealth sila, hindi rin sila nakaka-avail. One reason for this is, kunwari, less than 24 hours yung admission. Kadalasan ito yung mga medical cases natin. But for, as Opta, kadalasan kasi sa atin are procedures. So pwede pa rin mga OPDs and kahit less than 24 hours, basta may procedure, pwede siyang ipasok sa PhilHealth. Another reason bakit hindi nakaka-avail is no PhilHealth and patient does not want to comply. May mga pasyente kasi tayo na kunwari binigyan na natin ng mga requirements for compliance pero gusto nila or nagmamadali silang umuwi, gusto na lang nilang isettle yung balance or pumunta na lang sa social service. Another is yung non-compensable procedures or mga delisted na case rates. Mamaya ipapakita namin sa inyo yung mga delisted case rates sa Opta. And transfer to hospital of choice for medical cases. So kung na-admit siya sa atin and then same pa rin yung illness niya pero gusto niya lumipat sa ibang hospital, yung nag-receive na hospital na lang mag-claim and then isi-settle na lang niya yung bill niya sa atin. The last one is SPC or single period of confinement or the 90-day rule. Ito yung mga cases na hindi pwedeng maulit within 90 days na na-readmit yung patient. So kunwari nagkasakit na siya ng ganong case and then na-readmit siya within 90 days. Parang rin to. Kagaya rin siya ng transfer to hospital of choice kasi same pa rin yung illness niya within 90 days. Ito naman yung processing of patient's final statement of account for PHI situations. Ito naman yung may PhilHealth. So from sa start, i-forward nila sa atin dun sa billing section ng PhilHealth billing. I-receive natin yung face sheet and also check the completeness of Cf4, lab and radio results, and other needed documents. So, ang causes ng delay kadalasan are wala pa yung mga lab results or incomplete yung Cf4. So, ito yung kailangan natin bantayan lagi na kunwari ilang days na admit yung patient. Dapat everyday meron nakalag dun sa Cf4 niya. So, mas maganda pag daily din nag-accomplish yung mga residents or doctors natin ng Cf4 para pagdating ng discharge, kompleto na siya at hindi na lang ihahabol on discharge date. So pag okay naman yung mga lab and radio results, tuloy-tuloy lang. Another thing yung sinabi nga ni Dr. Yang kanina, yung kuminsan kasi yung PF forms, yun nga. Kuminsan nagko-cause din siya ng delay pag hinihintay natin yung PF, lalo na sa private patients. Kung wala pang PF yung doctor and then i-discharge na. Ang nangyayari kasi, ipa-follow up namin sa nurse and then the nurse will inform the doctor. Tapos yun, doon pa lang i-fill up during discharge. Kaya kung minsan hinihintay natin. And yan, pag Kompleto naman siya, dire-diretso lang yung discharge natin. So, lalo na pag isa rin pala yung sinabi ni Doc kanina, yung OR record or OR technique, kasi mostly procedure yung ginagawa natin sa Ophtha. So, kailangan talaga kompleto. And for emergency cases, dapat meron kang Cf3 pag wala yung CPSA. Ano ko lang din yung briefly discuss ko rin yung processing and transmittal of claims. So, after ma-discharge ni patient, i-collate lahat ng PHIC documents and prepare abstract report. And then i-verify and segregate all PHIC forms. And then, i-check din yung mga yung mga claim form 1, 2, 3, and 4. Tapos, kung may mga problems or may mga missing data. Ito, nagde-delay din naman siya ng processing kung upon processing, wala pa yung mga ibang lab or radio result na kailangan pang i-retrieve ulit para ma-send sa PHIC. So after that, i-endorse na yung PHIC papers, yung CSF, para ipasign sa doktor. And after the doctor naman, isa-sign ko for as a hospital representative sa PhilHealth. And then, yun, isa-send na rin siya through e-claims. So, basically, mabilis lang dapat itong process na to kung hindi tayo nagkakaproblema doon sa mga yung mga PHIC papers. And then, di-discuss na lang ni Ms. Roda yung mga PhilHealth circulars related to ophthalmology claims. Ito yung PC 2016-014, Annex 2, List of Procedures, Case Rate, and Supplementary Guidelines for all case rates. PhilHealth Cataract Package, Guidelines on the Diagnosis and Management of Uncomplicated Cataract in Adults, and List of Procedures and Case Rates, and Supplementary Guidelines for all case rates. Siguro after the discussion, pwede rin namin i-email yung complete PhilHealth circulars para for reference din ng lahat ng natin, doctors.
Hello po, good morning po. Ako po si Roda. So, ang i-discuss ko po is mga usual na RVS codes and meron yung mga delisted din po na natin. So, dito po sa slide, yung sa ay natin. So, meron siyang change, nabago po yung amount. So, from itong 65205, 3 something siya. So, nabago. So, 500 na lang yung case rate. And then the PF is 200. For HCI, 300 na lang. Yung corneal 65772, corneal relaxing incision for correction of surgically induced astigmatism. Kung gumagawa po tayo sa ganitong procedure, ito na po yung bago niyang case rate, 10,000 na lang. HCI, 6,000, and then for PF, 4,000 na lang po. So, meron po tayong procedures with additional condition for claiming reimbursement. 67010, removal of vitreous anterior approach, open sky technique or limbal incision, subtotal removal of mechanical vitrectomy. So, it cannot be claimed unless done in combination with penetrating keratoplasty, any of the following RBS codes po, yung 65710, 65730, 65750, 65755. Tapos 65005, removal of vitreous anterior approach, open sky technique or limbal incision, partial removal lang po siya. So, for RBS codes 67010, 05, 710, 730, 750, 7 cannot be claimed as second case rate. So, meron din pong mga procedures din for Opta din naman po na pwede siyang ma-second case. Pero, however, itong mga nabanggit po is hindi sila pwede. So, ito din po yung mga procedures natin na lifetime lang po talaga siya per eye. So, yung 65091, evisceration of ocular contents without implant po yan. 65093, evisceration of ocular contents. 65101, enucleation. Kung mga ginagawa po natin itong mga procedures na ito po yung mga RBS codes natin. And then, for cataract removal naman po, yung RBS codes 66840, 850, 852, 920, 930, 940, 982, 83, 984, and 66987. Yun po yung mga RBS codes na pwede nating magamit. So, meron po tayong illustration dito. For example, si patient A po, nag-undergo siya ng cataract noong June 1, 2015 sa right eye. Tapos meron siyang interval na isang araw, yung left eye naman po. So, pwede siyang mabayaran. Pero and after few months, nakatarak daw ulit siya yung right eye, yun po madedenay siya. Kasi ang cataract natin is once in a lifetime lang po. So meron din tayong mga reimbursement policy for RBS code 66820 and 66821. So yun yung dissection of secondary membranous cataract. So 66820 yung gagamitin po natin. Or yung dissection of secondary membranous cataract. Example nun, nag-laser 66821. So claims for RBS code 66820 and 66821 shall not be compensable if done less than 90 days after a cataract surgery on the same eye po. So both procedures can only be done once in a lifetime per eye. Meron ulit tayong sample dito. November, nakatarak siya. RBS code natin is 66987, November 1. And then after 90 days na po, February 15, nag-undergo siya ng dissection. It's either yung Ziegler or Wheeler knife ang doon. So, mababayaran po siya. Dito naman po sa number 4, na-deny yung claim kasi RBS code natin is 66987, left eye. And wala pang 90 days, 66820 ang ginamit natin. Same din po yung laterality. So wala po kasi less than 90 days po yon. For RBS codes 66820 and 66821 shall be exempted from the laterality rule. For bilateral dissection procedures, either RBS code 66820 or 66821 done in one operative session or with less than 1 day interval within the same or different confinements. The second dissection procedure shall be paid at 50%. Yun po. So pwede siyang magawa. However, yung isang nun is 50% na lang po. So dito sa illustration natin, first case rate natin 66821, right eye, June 15. Same day siya nagawa, pero 50% yung first case rate full and 50% yung second case rate natin. Pero pag different date naman po natin, yung una, yung right eye, and then meron siyang interval na 1 day, both claims papabayaran siya in full. So procedures exempted from the 90-day single period confinement rule. So meron din, kung meron tayong hindi mabayaran pag walang 90 days na interval, meron din naman pong exempted sa 90-day rule.
Minsan, pati Lourdes.
RVS 67036, vitrectomy mechanical pars planta approach. So exempted from 90-day single period confinement rule for the following medical indications only. So meron din po siyang dapat ang code natin na gamitin is H43.1 or H44.0 for purulent endophthalmitis. So, ang pwede pong gagawa doon is yung Philippine Academy of Ophthalmology and trained ENT, or yung GP naman po with completed residency training in ophthalmology. So, for vitrectomy mechanical pars plana approach with removal of dropped IOL, ayun po, yung pwede din pong gagawa doon is yung SAPAW and trained ENT. The Food and Drug Administration Philippines registered intraocular lens sticker or box used in the cataract surgery shall be attached to claim form 2 for claiming the following procedures. So ito na po yung mga cataract din natin. So in transition, the IOL sticker or box should be labeled with but not limited. Tapos po sa tatlo, yung product or brand name, model or reference code, manufacturer and serial number until yung August 31, 2016. So 1 out of 3 labels should be present and serial number. However, after na ng 2016, all 3 labels and serial number should be present. Otherwise, the claim shall be denied. As is, 1 IOL sticker shall be placed on the operative record and shall be part of the chart. To reiterate, the cataract surgery is covered by the CIPSA or Cataract Surgery Authorization. PhilHealth shall authorize only up to a maximum of 50 approved requests for pre-surgery authorization per PhilHealth accredited eye surgeon per month, not exceeding to 10. As scheduled surgeries per day per PhilHealth accredited eye surgeon, except for those performed by residents in training under the eye surgeon supervision with the PhilHealth Board of Ophthalmology accredited residency training program. The patients of residents in training not subject to limit shall only include non-private, service, and NBB eligible patients. So ito po yung illustration natin. So from August 5 up to August 2025, si Dr. De La Cruz, meron po siyang pina-approve na pina-approve na SIPSA for cataract. Nag-exceed na kasi siya. So from August 25, hindi na siya yung request na niya is na deny. Kasi in a month meron tayong 50. SIPSA shall no longer be required in cases of childhood, or ito po childhood and secondary. So example yung sa traumatic natin, glaucomatous cataract. So tatlo po yung hindi natin kailangan ng SIPSA. Pero po kailangan natin ng Cf3 properly filled out or accomplished Cf3 po sa childhood traumatic and glaucomatous cataracts. So, ito din po yung bagong yun yung nabanggit kanina ni Doktora, yung sa F3 natin. Yun po yung price. So far, wala din pong pagbabago. And ito na po yung mga delisted RBS codes natin. You check to me. Ayun. 654 kung yung mga may tilisyon po tayo, yung 6521 na lang po ang gamitin, hindi na yung 65420 kasi delisted na siya kay PhilHealth. So that ends po yung discussion.
Okay, thank you, Miss Roda, Mr. Chico, no? Miss Roda for discussing case rates and claims, and Mr. Chico for the workflows and algorithms followed in your department. So thank you for discussing also the reasons for the delay. This was very enlightening. So please take note, no, residents, nurses, as well as consultants, no, yung mga PF forms nyo to fill it up early and para walang delay, no? So just reminding everyone for the speakers evaluation, fill up the speakers evaluation. We will proceed directly to the next and final talk for the day. Paula.
Yes, sir. So now for our last speaker, he is a graduate of the Bachelor of Science in Social Work at University of Northern Philippines. And he's also currently taking his Master's of Arts in Social Work also at UNP. And he is a social welfare assistant here at our hospital. So let us now call on Mr. John Emil Urmeneta to talk about municipal social welfare and development services at Malasakit requirements. Sir?
Okay, thank you po, Doctora, for the introduction. Okay, so good morning po, everyone. Today, I will be talking about the programs and services as well as the Malasakit Center requirements here in our hospital. Okay, so to start, let me introduce to you first, why is there a social worker in hospital? Okay. Okay, so social work in the hospital setting is intended to serve as a support system of the agency to be a channel of patients experiencing psychosocial situations. Medical social workers, who are commonly termed as professionals handling on these various scenarios, are trained to conduct thorough interviews and assessment to patients, thereby formulating necessary interventions to help address their social issues. So, nagkakaroon ng social worker sa isang hospital kasi may mga pasyente tayo na iba-iba ang problema, hindi lang sa kadahilan ng sila ay na hospital, kundi sa kadahilan ng meron silang problema sa kanilang present environment. Okay? So, in our department, we are composed of 14 registered social workers and 4 administrative staffs. So, social workers in the descending positions are on shifting duties to cater the needs of the patient. So, just like any other offices, we are also 24/7 on duty. I mean, na may naka-duty po. Ganun. Okay? So, ito po yung aming mga pictures. We are headed by Mrs. Maria Teresa Sison, and we have 3 social welfare officer 2, and then the rest are social welfare officer 1 and social welfare assistants. Okay? So, in social service, we have 3 major programs and 1 special center, that is the Malasakit Center. So let's start with the social case management process for hospital patients. So under this, patients are experiencing psychosocial problems upon admission or as referred by any concerned health worker. Such Patient's problem may be in the form of their social interaction in the current environment, unidentified patients, patient with severe or chronic illness, and the like. Social workers is skilled on providing psychosocial interventions such as counseling, networking, resource mobilization, crisis intervention approach. Interagency referral is also practiced to patients who needs continuous management of the case if hospital resources are not available. Okay, so like in any other scenarios, we do offer counseling sa mga pasyente na minsan multiple na ang kanilang problema. So we do offer services and we do offer opportunities for them para makagas sa kanilang problema ngayon, okay? And then resource mobilization, example of this is yung ating OSL, no, sa ating mga admitted patients. And then sa crisis intervention approach, minsan may mga nire-refer dito na mga walang bantay, na hindi mahanap ang mga family, or hindi malukik-lukik kung saan talaga siya nagmula. So, iyon yung aming mga ginagawa dito, okay? And then, under the social case management process, we have here support programs and services. So, una dito is yung tinatawag nating MHPSS o yung mental health and psychosocial support. So, along with dealing to mental health issues facing by social workers' client, this service is intended to promote the condition of them by providing an avenue to release their catharsis. This is designed for them to release their feelings on situations where they felt distress. So, hindi lang mga pasyente ng ITRMC ang binibigyan ng MHPSS, no? So, as of now, since may mga kasama tayo dito sa hospital na na-COVID din, we also provide MHPSS, no? So, ang MHPSS po ay under kay Dr. Ramos, ang ating psychiatrist, okay? And then, ito yung corneal transplant. Ito na is connected sa Ophtha department. No? So, ang role ng social worker dito is to provide grief counseling through the family approach to patients who is willing to donate the corneal tissue to an unidentified beneficiary. Okay? So, under this, we have two trained social workers in the person of Ms. Ada Carisma Dazon and Ma'am Esther Painor. So, sila yung representative ng social service when the Ophtha department invited us in the Eye-Bank Foundation of the Philippines, somewhere in Manila. Okay? Bago ata ito mag-pandemic. Yan. And then, next is yung convalescent plasma. So, COVID patients with severe to critical category and is subject for convalescent plasma transfusion are referred to social worker for assessment. A thorough evaluation is being conducted to provide medical assistance to the patient. Ito namang convalescent plasma po natin, ito ay kasama natin ang IM. So kasama ng IM dyan is yung St. Luke's Medical Center kung saan sila yung kauna-unahan na nagbibigay ng convalescent plasma dito sa mga COVID patients. So ang ginagawa ng social worker dito is ina-assess yung pasyente and then nire-refer doon sa social worker din ng St. Luke's. Okay? So, ang convalescent plasma sa ating mga NPB patient ay covered po ng Security Bank Foundation. Okay? And then, yung panghuli po natin is yung provision of crutch and wheelchair. So, indigent patients, especially those who met orthopedically and are in dire need of these tools, are assisted by medical social workers. So, this can also be in a part of information campaign to other entities, no? Not only ortho patients, but all patients who are really in need of this tool. Okay? So, let me share to you yung mga features po ng aming mga activity or services po na pinaprovide dito sa social service. So dito po sa ating una, ito po yung ambulance conduction. So, we have John Doe patient noon na I think nawalay siya at napadpad dito sa La Union for more than 30 years. So, yung paglulocate sa kanya is talagang nakaka-struggle sa part ng social worker kasi talagang kailangang kausapin, interviewin yung pasyente. Ang problema nga lang doon, kung hindi pa ganoon kalapit yung kalooban sa'yo ng pasyente, so kailangan mong mag-build ng rapport ulit. No? So very important yung pag-establish ng rapport sa ating mga pasyente. And then dito sa second, ito yung MHPSS. No? Pero hindi po ito sa COVID ward. Ha? Binigay lang po ito doon sa somewhere sa ating laundry. And then ito yung, ito na, yung isa ulit sa ating Jane Doe patient. No? Nanawalay din at napadpad dito sa may Tagudin, Ilocos Sur. So nalocate ang kanyang family in Makati City. Ito yung, itong nakaupo is yung sister. Okay? Then, we also attended trainings, pero this is before pandemic pa. Yung ako para sa bata, connected ito sa ating WCPU. And then, we also have coordination with the local social welfare officers. Okay. So as of now, hindi pa kami nagkakandak ng ward rounds sa ating mga pasyente. But in some cases where the patient is in need or have a special case, rather, pinupuntahan niya ng social worker, kinakausap at nagkakaroon na ng assessment doon, kahit initial assessment lang. And then for the next few days, doon na ulit magkakaroon pa ng information gathering para makuha at makapag-formulate ng necessary intervention ang isang social worker. Okay? The next, we have the PhilHealth Point of Service Program. So this is being provided to patients assessed as indigent without PhilHealth, considering that they are admitted on charity basis. This can also be applying to patients who are coming from emergency cases, such as animal bite category 3, OB cases with dilation and curettage, oncology, and HIV. So, ang POS po dito sa ating hospital and to any other public hospital, social worker lang po ang natatanging magbigay ng POS. No? So, kapag ina-assess na ni social worker na ang isang pasyente ay indigent at wala siyang PhilHealth, ma-admit siya, yan po ang binibigay namin as primary intervention para sa kanya, no? Para magkaroon siya ng PhilHealth. No? Pero sa case natin, since marami ang nawalan ng trabaho, marami ang natanggal sa trabaho, at marami ang walang trabaho, so ito yung binibigay namin as number 1 intervention, lalo na pag sila nga ay yung ma-admit. Okay? Then next, we have Women and Children Protection Unit. So, medical social workers' role on this part is to conduct or investigate situations in which a person may be at risk, thereby formulating safety risk assessment to women and or children who suffered from abuse or neglect. Multidisciplinary consultation from various professionals, such as law enforcing authority and doctors, are being performed to give emphasis on the situation of such victim. Okay? So very familiar ang ating mga nurses sa emergency room ito. So kapag sinabi ng may VR, automatic tinukol ang atensyon ni social worker para magkaroon ng interview at makapagbigay ng safety risk assessment. No? So gusto ko lang i-stress na sa WCPU po natin, kapag na-assess ni social worker na ang isang pasyente o isang VR case ay red flag na, ino-offer natin ang halfway house dito sa ating hospital. No? Ang halfway house po natin ay good for 48 hours and then ang follow-up niyan ay ine-endorse sa local social welfare officer kung saan nanggaling ang pasyente. Okay? So once na lumabas na si pasyente dito sa hospital, meron ng idea si local social welfare officer doon sa munisipyo kung ano yung pwede niyang gawin dito sa ating pasyente. Okay? Average po, additional information lang, average na nakikater ng social worker o ng WCPU dito sa ating hospital is about 18 to 20 patients per month. No? Lahat yun ay minsan meron ding mga lalaki na VR cases, pero more on, ano lang yun, tawag dito, mulling, parang ganun. Okay. And then, we are now on the last part sa ating Malasakit Center. Okay, so the Malasakit Center is a presidential mandate initiated by OSAP, or yung Office of the Special Assistant for the President, in cooperation with the DOH retained, provincial or city LGU-operated hospitals in selected regions, PhilHealth, DSWD, PCSO, and Office of the Presidential Assistant for the Visayas. So Malasakit Center is a one-stop service center of government services instituted for the purpose of expediting processes in availing of services relevant to healthcare, primarily for but not limited to financial assistance. Okay? So let me share to you some of the pictures ng ating Malasakit Center. Ang ating Malasakit Center po ay mag-anniversary na this December. Okay. So let me talk to you about the requirements for each agency located in the Malasakit Center. So unahin natin ang DSWD, no? So nagtataka kayo kung bakit maraming tao sa Malasakit Center. It's because iba-iba rin ang problema na kinakailangang i-address natin doon. Okay, so depende yan kung ano yung ipararating ni pasyente doon sa social worker sa Malasakit Center. So naka-indicate po dito kung ano yung ipapatulong nila. So meron na tayong mga requirements dito na nakalista. No? Gusto ko lang po i-stress na lahat po ng nagpapatulong sa Malasakit Center ay dapat galing sa government hospitals. No? Pero pag sila ay galing sa outside, like yung mga private hospitals natin or private clinic, hindi naman po namin sinasabing hindi pwede, pero sila po ay nire-refer sa DSWD Regional Office. So, ibig sabihin, ang kinikater lang po ng ITRMC ay pasyente rin ng ITRMC o pasyente ng ibang other government hospitals. Okay? So, ito siya. Yan. And then next, we have also the PCSO. No? Sa PCSO naman po, meron tayong tinatawag na IMAP or yung Individual Medical Assistance Program for private patients, and for the MAP, we have also for the charity patients. No? So bakit merong private sa PCSO? So depende yan sa social worker ng PCSO kung siya ay magbibigay ng assistance doon sa ating private patient, except professional fee. Okay? So depende rin po sa kanya yan kung ano yung assessment niya. We cannot influence the social worker of PCSO kung siya ay magbibigay o hindi sa ating mga private patient. Pero siyempre, priority pa rin natin ang charity patients. Okay? So not only on the hospital bill, pero tinutulungan din niya ang ating mga dialysis patients through their erythropoietin injection at saka sa ating mga onco patients sa kanilang chemo drugs. Okay? Then next, we have also the PhilHealth services. Ang ating PhilHealth representative po ay nanggagaling sa kanilang office dito sa may CSI. So, ang role naman ni PhilHealth doon sa Malasakit is yung PBEF, no? Or yung validation of PhilHealth membership status. Nag-enroll din siya ng, sa PhilHealth, nag-enroll din siya ng mga senior citizen na hindi pa pumasok yung kanilang membership at saka yung mga emancipated patients po natin. Okay? And then, pwede rin po tayong mag-refer sa kanya with regards to POS. And then, we have also the DOH ITRMC MAIP. Okay? So, ang MAIP po natin, minsan nanggagaling sa Central Office ng Funds, meron din nanggagaling sa Regional Office ng DOH, at saka meron din nanggagaling sa ating mga legislators. So, depende yan kung magkano yung amount na ibibigay po dito sa ating hospital. Okay? So, ang MAIP, that is in the form of the SAA o yung sub-allotment fund. Okay? So, ang purpose ng MAIP is for hospital bill, then for ancillary services. Yan. Okay. So, ito na po yung pictures ng ating Malasakit Center. no, kung ano yung ginagawa doon sa malasakit. So number 1 pa rin dyan na tools naming mga social worker is to conduct interview. Hindi mawawala ang interview pag ikaw ay social worker, no? Interview tsaka pagsusulat. Okay? Yan. Okay? So minsan, pag ang pasyente ay hindi nakakapunta sa malasakit, wina-wire drums din po yan ng ating mga representative to give the appropriate services they needed. Okay? Yan. Okay, so meron din tayong meeting with our management with regards to Malasakit Center. Yeah. Okay, so that's ends of my presentation. Maraming salamat po.
Thank you so much, sir, for that lecture po. So, if you have any questions, just feel free to type them on the chat box below. And reminding again everyone to please fill up the evaluation forms. So for our, may I call on, sir? Sir Juan?
Yes, so thank you po, Lana. So we are opening the floor for questions, maybe a few questions. You can entertain a few questions. So we have already actually one. Can you read the question, Paula? I'll read it already. So for Mr. Ormeneta, sir, are you still there?
Yes, Doc. Yes po.
One question here is from Ma'am Aiso. Ma'am Aiso, regarding financial assistance for medicines, makakapag-avail po ba yung patient ng financial assistance even if wala sa pharmacy, yung gamot, and how frequent sila pwede mag-avail? Or kung may limit daw po?
Yes po. With regards to financial assistance para po sa ating gamot, ang number 1 po dyan na pinapalo po natin sa Malasakit Center is kung yung gamot pa na kailangan is hindi available sa pharmacy. Okay? So pag hindi available sa pharmacy, doon po lumalapit yung pasyente sa ating Malasakit Center through the DSWD representative for the assessment. Okay? So discretion na po ni social worker ng DSWD kung magkano po yung assistance na ibibigay niya. Okay, so gusto ko lang din po i-stress na ang pagbibigay po ng financial assistance ng DSWD sa ating Malasakit Center is good only after 3 months. So kunwari nakakuha ka ngayon ng assistance sa DSWD, after 3 months pa ulit yung pwede. Okay? Yun po, Doc.
Okay, thank you. Thank you, sir.
Thank you po.
I actually have a question also for you.
Yes, Doc.
Sorry. Very happy anniversary to the Malasakit Center.
Thank you, Doc.
So for ang question ko lang is yung you presented yung mental health support.
Yes po.
So I always thought na yung mental health support will pass through the psychiatry department. Pero how do we refer patients in need to this part of your social service?
Yes po. Usually kapag pag nire-refer kasi ang pasyente dito sa amin, kailangan kasi is ideally kailangan kasi is face to face. Pero since nga meron tayong pandemic, linilimit natin yung interaction. So we do give the MHPSS through the digital procedure na lang. Pero kung sakasakali sila ay group, yan ay nire-refer sa amin, and then multidisciplinary kasi yung merong doctors na na-train, nurses and social workers para mag-conduct ng ganong support para sa ating mga pasyente.
So anytime we can
Yes po, Doc. Yes po, Doc. Yes, Doc. Opo.
Marami ba nare-refer?
As of now, Doc, since nung nagkaroon nga ng mga COVID patients dito na mga kasamahan natin dito sa hospital, marami din po, Doc, yung binigyan po natin ng ganoong support. So it's also time for them to, alam mo na, ventilate their feelings.
Yes, kasi I think very important to.
Yes po, Doc. Yes. Very timely po, Doc, yung pagtanda po ng HPSS.
Hindi kasi lahat financial support lang. Basta narinig mo MS social service, parang financial.
Parang financial.
Meron din, di ba?
Yes po, Doc.
Aside from yung yung women's desk or halfway house, no?
Yes, Doc.
So thank you again, Mr. Ormeneta, for
okay, Doc. Thank you po.
Answering our questions. I think we don't have any other question. It's already 11:20. Meron. Okay, go.
One last question po from one of our consultants, sir. Regarding the additional 1,730 na additional sa bill, sir, to our patients, which was just recently implemented po. So, about that lang po, sir. Kumusta po?
Come again, Doc? Come again?
Yes, sir.
Dr. Mervin to.
Yes po.
Sa PHIC sana yan kasi may napansin lang kami and we've been informed that there's sa PHIC sir kay Sir Chico may nagiging additional na 1,730 I think na additional on top of the case rates being charged to our patients. So our patients are being asked to pay than the dati na binabayaran nila. So we just want to be clarified on that.
Doc, may certain procedure kaya doon sa charge kasi siguro dahil dyan sa implementation ng meron kasing bagong circular yung PC12 which is ang babayaran ng PhilHealth starting August 22. Is whichever is lower between the cost ng actual or your package. So I'm not sure dun sa 1,750 pero ang pwedeng maging reason is walang na-charge na mismong procedure nung ginawa. Kaya yun din ang i-remind natin lalo na ngayon yung PhilHealth kasi ang binabayaran na niya hindi na yung package. So kung may mga ginagawa tayo na hindi na-charge, ang babayaran lagi ni PhilHealth whichever is lower na. So ko rin Doc kung yung 1,750 na yan kasi hindi rin ako aware. But probably ganun yun yung instance na ganun. Pero pag sa lang dapat yun sa charity patients natin para wala pa rin bayaran at maklaim pa rin natin yung package in full. Pero kung sa private yun, dapat walang
Balik din, Sir Chico, yung example ko lang yung sa akin. Yung 1,730 kasi nakuha ko lang kay Ma'am Aiso kasi yun yung explanation nung doon sa billing. Pero personally, yung nangyari sa akin, nag-laser ako last week. YAG capsulotomy. Post na cataract ko, nag-laser lang ako. So ang charge ko was PhilHealth only. Kasi meron naman ako makukuha sa PhilHealth, so PhilHealth only. Nung dumating na yung bill, may pinabayad sa patient ko na additional 400 plus o almost 500 pesos. So dati naman kasing walang binabayaran. Then yun nga, nabigla kami parang may pinabayad na 500 pesos.
Ano yun, Doc? Baka sa actual charges? Hindi dun sa fiat portion or ano?
Hindi ko lang alam sa kasi Ma'am Ice yung ginawa lang niya yung the usual na ginagawa namin dati. Then bigla nung pagbalik may additional 500. Siguro na lang we'll just talk with you on a different venue na lang regarding
saka yung actual na Doc para at least ma-check natin yung bill.
Yes sir. Sige, para alam din namin kung paano yung gagawin namin kasi hindi lang ako, meron yung ibang consultants din parang may additional charges na nadadagdag. So siguro we'll just ask you on a different venue na lang.
Yes, Doc.
Pero next week na lang punta na lang kita.
Sige, Doc.
Okay, thank you.
Oasis pala.
Sige. Thank you.
Sige.
Okay. Thank you, Dr. Mervin. Thank you, Mr. Chico. So if there are no questions ka pa ba dyan, Paula?
Wala na po, sir.
Wala na. Sige, we'll end na, no? Because it's about magla-lunch na tayo lahat. So just a recap lang, no? Just a summary, no? For the past 3 sessions, 3 Saturdays, we discussed basics of clinical ophthalmology, some safety protocols. The focus really was the workflows and practical tips, no? Used at the OPD, Eye Instrument Center, and WARD, no, as a whole, as well as some accounting and social service talks. No? So, Paula, can you end the session already?
Yes, sir. So, Again, so this wraps up our first virtual ophthalmic support staff course, and we do hope that you all the discussions or at least stimulated your interest in ophthalmology, and hopefully you can apply your new learnings when you rotate with us. So we will make sure to read your comments or if you have any questions or suggestions to improve on the course and our speakers. So regarding the link or the copies of all the lectures, we will be sending a link. So just stay updated with that. So we would like to thank all the nurses and guests for attending our 3-day course. And also we'd like to thank all our speakers, Dr. Gabrielio, Dr. Peña, Dr. Concepcion, Dr. Young, Mr. Chico, and Mr. Urmeneta for all those lectures that you have given today, and also to our technical team for helping us, and also our chair and all our consultants who helped us with this event that will make this possible. So again, please don't forget to fill up the attendance sheet. So if we have no more questions or no more concerns, so I would like to thank everyone. So enjoy the rest of your Saturday. So thank you.
Thank you for attending.
Thank
See you next year again.
Okay, so I would like to ask everyone to please turn on your cameras just for last picture taking. Okay. So again, so smile. 1, 2, 3. Okay, 1, 2, 3, smile. Okay, we have one more. 1, 2, 3, smile. Okay, I think that would be all for today. Thank you, everyone. Thank you po.
Thank you po. Thank you po.
Po, Doc.
before we close the program, before we close the link, may I request all the consultants and the technical team to kindly turn on their cameras for picture taking. Dr. Umel, kindly facilitate the photo session, please.
Ka na ba?
Oh, sir.
Hello, sir. Turn on your camera.
Ay.
Kumukuha ka na ba? Or
Ay. One more.
Naka-smile na ako sa camera, wala pa pala.
One more pa. Sige, si Ali na lang po.
1, 2, 3, smile. One more. 1, 2, 3, smile.
Thank you po.
Okay, thank you everyone. Salamat sa tulong. So next year, kung meron ulit,
yes.
Ikaw na Paula, tsaka Paula ka na yata, Paula pala.